Can you believe that? I didn't set it up and now it works. Go figure. Welcome to Bad Medicine with Miss P. Today we're going to talk about enzymes, and basically it's pretty simple. Those are the little SOSs that your organs and sometimes muscle and other tissues send out into the bloodstream to let them know that there's a problem. So whether it is liver enzymes, pancreatic enzymes, muscle enzymes, cardiac enzymes, whatever it is, it's basically a little SOS sent out into the bloodstream so the body knows that there's a problem and this organ is having some tissue damage. Usually it's from tissue damage. So way back when we had your CK, CKMB, and troponin were our cardiac enzymes. Well, they kind of decided that troponin is really more the best specific test for cardiac enzymes. And when I researched it years ago, and from what I remember, basically what they were saying is troponin wasn't necessarily an enzyme. It was kind of a byproduct of the specific, but at any rate, it will let you know if there's a significant problem, more so with the heart than any other tissue. So sometimes if you have, let's say, a patient that fell or had a seizure or anything like that, they could have elevated CK and CKMB, or rhabdomyolysis, like when horses tie up, their CK and CKMB are just off the charts because it's basically like a Charlie horse in every muscle fiber. So it sends out those enzymes to let the bloodstream know that, we've got a big issue. So sometimes you'll see that with patients that have had a fall, like a broken hip. Sometimes even with a broken hip, the CK and CKMB are elevated, but the troponin is completely unaffected because it's not a heart, it's the tissue around that hip that has sustained damage. And sometimes you can figure out if they either had a seizure and then fell and hit their hip, depending on those levels. It's not, perfect, but it can give you an idea. We've seen in the past, like I've been at the hospital with the patient, and I'm looking at those enzymes, and I'm like, yeah, those are high from the damage of the muscle, but those are really high. So I'm kind of thinking she had a seizure, and then sure enough, down the line, we see that they start her on Keppra or phenobarb or something like that. And then I'll tell the student, I'm like, see what I mean? This is why I thought that, because those enzymes were so greatly elevated. We're talking, thousands times the normal limit or levels. So same thing with your cardiac enzymes, and that's why that's one of the first things we do when a patient comes in complaining of chest pain. We're going to get those cardiac enzymes. We're going to put oxygen on them, obviously. We're going to do a chest x-ray, an immediate EKG as quickly as we can, and then determine whether we need to, go from there. So those enzymes are what let us know. Now, the problem is with initial damage, obviously, all of those enzymes are not going to shoot out in the bloodstream and bolt over to the left AC where you're drawing the blood. So a lot of times, like I even had a patient wake up from surgery, and this is outpatient surgery. This is like, we don't do, nights, holidays, weekends, and trauma. Like that's, don't code at our center. That's, we can take care of it. We are completely capable of taking care of it, but stop it, because we want to go home when surgery's over and not transfer someone to the emergency room and be there all night trying to figure out what's what and fax over all the information. Like just don't do it. So when this happens, patient wakes up, and I'll never forget this, he wakes up clutching his left arm, and he's already like squinting and, grimacing, and I'm thinking, he's not even awake yet, he hasn't even opened his eyes yet, he hasn't even done the, what time is it, were you in there, is surgery all over, how many stitches do I have, what time is it, can my wife come back, were you in there, how many stitches do I have, he hadn't even started that, right? So he's literally eyes closed, and he clutches his left arm in his sleep, I guess, and he starts grimacing, and I'm thinking, you gotta be kidding me. So the anesthesiologist is like, you can go ahead and get a set of enzymes. And I'm like, we will. So we drew cardiac enzymes, but of course they're going to be normal, because even if he's having an MI right now, they're not all going to jump out of his heart, bypass his entire circulatory system and bolt over to the left AC where I'm drawing his blood. So of course they're going to be normal or, reasonable. Well, then you have to draw them again in 6 hours and then again in 6 hours. That's why you hear something like serial cardiac enzymes. And those things do change. Last time I was there, I think they only get 2 now. If they're not going up by then chances are they aren't. And, all this medicine, all these things are constantly changing. Everything in medicine is constantly changing. So if I say something and you're like, oh, we don't do that anymore, well, good. Let me know in the comments and I'll correct it, because, I'm not out there anymore. I was for a good long time with the students. So this is all I know now, and this is all I can, teach you. And if something's different or wrong, let me know. There's some stuff that I will fight you to the death on, and some stuff that is changing all the time, like the pro-BNP. I researched that a little bit, and I still have to kind of get a better understanding to where I can explain it to somebody, to where if they had questions, I really know, like I know. So I'm still kind of working on the BNP that we were doing way before. I looked into the pro-BNP a little bit. It's somewhat confusing, but I do still see them draw BNP, so that's still helpful. But with the enzymes, basically whether it's, pancreatic enzymes, the patient comes in and, she's just having like severe abdominal pain and she's nausea, vomiting, and hasn't eaten anything in 3 days and is, listless and miserable. Yes, we have dehydration, but that's when we check those pancreatic enzymes and determine, is she in pancreatitis, and that's a big issue. Liver enzymes, we'll see those elevated a lot with cirrhosis or patients with liver disease, that sort of thing. When we get a patient getting ready to have surgery, not so much at this surgery center, but where I used to work, if a patient came in with elevated enzymes, and we used to get a CBC, a BNP, and a UA on every patient having surgery. We don't necessarily do that anymore, at least not where I work right now. They're just finding that it wasn't, nearly as important. But if a patient came in, like I said before, and they had a decreased sodium, well, the first thing we're going to do is give them fluid. So we may even cancel that case, depending on how severe their sodium level is. Same thing with their liver enzymes. The anesthesiologist would walk over and say, hey, do you have cirrhosis? Do you have any liver issues? And they're like, no, what he's talking about. He's like, take care. Go ahead and get dressed. You need to find out why your liver enzymes are elevated, because the anesthesiologist is going to fill in with a whole bunch of medication that is going to be processed and excreted via his liver. So obviously we're not going to give him a whole bunch of medications that he can't process and get rid of. And that's where we see a lot of that I want to say digestion, but use and excretion is through the liver. So we cannot possibly give him a whole bunch of medication that he can't tolerate. So when he's in recovery and he's not waking up because the liver is not getting rid of that medication, so that half-life that should be 3 hours is now going to be 6 hours or even longer, depending on the level of liver damage. So that's what enzymes are. They're letting the body know that there's a problem to that specific organ or that tissue, your muscle tissue in that case. So, and those are the most common ones you're going to see. We can talk a little bit about the BUN and creatinine with like kidney damage. I don't know that there's necessarily kidney enzymes. The BUN and creatinine are kind of those specific levels reading from your kidneys to let us know if we're having any kidney issues. But the BUN and creatinine can also be a little misleading. What I'm finding over the years is that if that BUN is a little elevated, that creatinine, remember that is also drawn from a deciliter of fluid or a specific, a part of that fluid, that bloodstream. So you could have almost a false negative. So if they are significantly overhydrated and filled with fluid, when you draw that, it still should be elevated if they have kidney disease, but sometimes it's not nearly as clear. So what I found, and what I just talked to a patient yesterday, he takes 40 of Lasix every day and insists that he doesn't have any kidney disease. I'm like, that's Lasix works in the kidneys, and we're going to get into that in more detail. And I'm trying not to educate these patients too much over the phone because they don't want to hear it, and their doctor already told them their kidneys are fine. And every single time, not once or twice, not often, every single time I'm looking over the med list with the patient, with the student, and we see that the patient is on 20, 40, 60, 80 of Lasix, nowhere in the history does it say they have any kidney disease. Nowhere in the history does it say they have any level of renal failure. I already know that that's chronic kidney disease stage 2 or 3. I already know that, because why else would they be on 60 of Lasix? The BUN and creatinine are maybe a little elevated, but not necessarily indicative of significant kidney failure. And then the GFR is 24. I'm like, yeah, that's your glomerular filtration rate is significantly decreased. And then what I even like on the lab list is it'll show you if it's this much, they have this stage. If it's this much, they have this stage. It's your little sliding scale there. So when it's 30, they're already in chronic kidney disease stage 3. When it's 50 or 60, they're already in chronic kidney disease stage 2. And they're like, no, my kidneys are fine. I'm like, well, this lab value tells me otherwise. And why are you taking Lasix? Why are you taking a medication specifically to make your kidneys work correctly? If your kidneys were working correctly, you wouldn't need Lasix. I don't take Lasix. None of my friends take Lasix unless you have kidney disease. I even worked with a nurse for the longest time that she's like, my kidneys are fine. It's for heart failure. Okay, I'm just going to touch on this a little bit because this is going to be an hour-long video at some point. If you are taking Lasix because you think you're in heart failure, that means your kidneys aren't working. And I know you think it's because, well, the heart's not perfusing the kidneys, and yet it's perfusing your brain and your liver and your pancreas. Did you also become diabetic? No, you just went into fluid overload. Okay, and your heart's still working correctly. It's still getting its blood supply, and you haven't lost a toe or a finger. It's just completely ignoring the kidneys. I'm pretty sure you've either pressure cleaned your kidneys for decades with uncontrolled hypertension, or you have such poor perfusion that you didn't perfuse the kidneys at all, and they've lost their blood supply. Either way, if you're taking a pill to tell your kidneys to work correctly, then you have kidney disease. It's that simple. Just like when a patient comes in and says, oh, I don't have high blood pressure, I take a pill for that. That's because you have high blood pressure and we're keeping it controlled with your metoprolol or your lisinopril or your losartan. So if you're taking a kidney pill every day, you have kidney disease. You don't have to like it, but you have to accept it at some point because those are the facts. The patient I talked to yesterday, I thought for sure I was going to have to reach through the phone and choke this sweet 80-year-old man, but 40 of Lasix a day. Nope, doctor says my kidneys are fine. Okay, it's my heart. Okay, but you're not on any heart pills? All right, that seems weird, but okay. When we get to medications, we're going to go into great detail. And you know what? I think that's coming up pretty soon because the only other lab I've got listed here to really talk about is your D-dimer. We saw a lot of those elevated recently, haven't we? Yeah, I'm not even going to get into that. Your D-dimer is elevated when there's a blood clot in your bloodstream. Little bits, let's say pieces, specific particles of that clot are released into the bloodstream to let the rest of the body know there is a clot present. And that's how you know you've got either a PE, maybe a DVT, not so much the MI. Once you got a clot for an MI, you kind of just have an MI. So that's a little, I don't even know if your D-dimer is necessarily elevated at that point, but usually those symptoms kind of, raise their ugly head a whole lot sooner than you can waste time getting a D-dimer. But if you have an elevated D-dimer, and we saw a lot of those the past couple years, that means there's blood clots somewhere. So pay attention to that, and if you suspect it at any time, don't be afraid to ask the doctor. Say, hey, can we just go ahead and draw the blood and check for D-dimer? They have this symptom, or they have this, or I'm worried about this, or they've had a history of this, so don't be afraid to check on that. And that's about it for labs. And don't forget this fabulous diagnostic lab book. For those of you that graduated years ago, take the plastic off of it and use it. It's good stuff. For those of you that don't have it, not that you can't use your phone, but still, it's a good book, and it's not that expensive. So I bet you can get it dirt cheap on Amazon or wherever you get your stuff. Oh, and I haven't told you guys in a long time how important it is to face your fears, forget your failures, and follow your faith. I always loved that, and I had planned to I planned to end each video with this sweet little uplifting message, but in pure Miss P style, I instead just leave it with a pet peeve, and this is my new one. And you know what? It's not fair y'all add stuff to me, but now that I know this, I inadvertently called an interpreter a translator to her face. I didn't know that was like an insult, and not necessarily an insult to her, but apparently an insult to my intelligence, because she immediately corrected me that the translation is on paper. You translate the written word, you interpret verbal language, and well, now we know, and you're welcome. So every time you hear that from now on, it's going to burn your butt. Sorry, it's kind of what I do. So now that we've taught all this, so okay, now I'm scared because I think I finished all of the easy stuff, and we're gonna have to get into the hardcore stuff. So I will either start with meds or disease processes. Maybe we'll start with meds. Yeah, we'll do meds, and then when we talk about the diseases, we'll be able to apply those meds to those diseases. And then that's all I got. This is my extended IV therapy course. So after we do meds and diseases, I'm going to read off some of the fabulous things over the years that I've seen, either written, spoken, heard, or charted, and then that's going to be it. And then I won't have to do this anymore. And then I can go through my closet and start selling all of the stuff I have collected over the years from Uncle Harry and other people that I've just acquired all of these fabulous things that I know are probably worth lots of stuff. You know, like a Zsa Zsa Gabor wig. Uncle Harry sent me a Zsa Zsa Gabor wig. You never know. It could be worth some money. I'm going to put it on eBay, see what I got. I got some old purses. Apparently there's a Prada wallet I'm obviously never going to use. Those things go for like $100 for a freaking wallet. I'd be carrying around an empty $100 wallet. I can't. It's so dumb. Okay, anyway, so that's it. 15 minutes. Ooh, look, I made it. Okay, love you. Hugs and kisses. See you soon. And this is probably not going to work this time because that's how it works.